Pretty frequently when somebody mentions the cardiovascular system, we automatically think of the heart. However, it's much more complex than that. So it's quite important to us because it helps deliver oxygen and nutrients. It carries things like hormones throughout the body, carries away waste, such as carbon dioxide in the blood, via the blood. It does this, the center of the cardiovascular system is the heart, but the heart pumps blood throughout the body in blood vessels, and blood flow requires both the pumping action of the heart and changes in blood pressure. And if the cardiovascular system, for some reason, cannot perform its functions, waste does build up in tissues. Consequently, body organs fail to function properly, and then once oxygen is depleted because that heart is no longer pumping that oxygen around the body, tissues, organs, people will die. So this image here is just kind of showing you the relative position of the heart when it comes to the lungs. Size-wise, the heart is about the size of your fist. You can see that it sits kind of at an angle. It sits enclosed within the inferior mediastinum, which is the medial section of the thoracic cavity, and it's flanked, like I said, by the lungs on each side. The pointed apex points towards your left hip. So usually we think of apex and we think of top. It's actually the bottom pointy part of the heart. Pointy, more pointy, I would say, than the rest of it. It's like I said, directed towards the left hip and rests on top of the diaphragm. Approximately at the level of the fifth intercostal space. So if you were to want to auscultate or listen to with a stethoscope the apical pulse, this is where you would listen to it. Its broad posterior-superior aspect is the base, and this is where the great vessels of the body emerge. It points towards the right shoulder and lies beneath the second rib. So you can see we have the pulmonary trunk, which is exiting the heart and going into the lungs. You have the superior vena cava, again the diaphragm that rests right below your lungs that help with expansion of the lungs on inhalation and pushing all the air out on exhalation. We have the aorta, primary artery of your body, and then your parietal pleura. So obviously in this image it's cut so you can see the lungs, the pericardium, which is also cut so you can see the heart, and again the apex of the heart. These images just provide additional information about relative size and placement of the heart. Again, in B you can see that midsternal line. Your heart's resting directly behind your sternum in your thoracic cavity, with that apex turning and pointing towards the left hip. In C, we can see at the top of the photo, just the front of the body, the anterior portion of the body, the mediastinum, and then the heart sits flanked on each side by the lungs. Posterior to that would be your spinal column. So heart wall in its covering. So the heart is enclosed by a sac called the pericardium, which we saw in the first image. That's made up of three layers, an outer fibrous layer and an inner inner serous membrane pair. The loosely fitting superficial part of the sac is referred to as the fibrous pericardium. This fibrous layer helps protect the heart and anchors it to its surrounding structures, such as the diaphragm and the sternum. Deep to the fibrous pericardium is the slippery, two-layered serous pericardium. We have the fibrous pericardium and then the serous pericardium. The parietal layer of the serous pericardium, or parietal pericardium, lines the interior of the fibrous pericardium. So fibrous pericardium, parietal pericardium. And at the superior aspect of the heart, this parietal layer attaches to the large arteries leaving the heart and then makes a U-turn and continues inferiorly over the heart surface as the visceral layer. The visceral layer of the serous pericardium, or visceral pericardium, also called the epicardium, is part of the heart wall, so closest to the heart itself. In other words, the visceral pericardium is the innermost layer of the pericardium and the outermost layer of the heart wall. Lubricating serous fluid is produced by the serous pericardial membranes and collects in the pericardial cavity between the serous layer. So this fluid here is quite important because our heart is a moving organ, and this just allows the heart to pump and move in your chest in a frictionless environment. So it's sliding smoothly because of that serous fluid. The heart walls are composed of 3 layers. So you have the outer epicardium, so the visceral pericardium as just described, the myocardium, and the innermost endocardium. The myocardium consists of thick bundles of cardiac muscles, so that involuntary muscle that we learned about, and that's whirled into ring-like or figure 8 arrangements. It is the layer that actually is doing the contracting for the heart. Myocardial cells are linked together by intercalated discs, which contain both desmosomes and gap junctions. The gap junctions in the intercalated disc allow ions to flow from cell to cell, carrying a wave of excitement across the heart. The myocardium is reinforced internally by a network of dense fibrous connective tissues called the skeleton of the heart. The endocardium is a thin, glistening sheet of endothelium that lines the heart chambers. It is continuous with the linings of the blood vessels leaving and entering the heart. And we'll see a figure on the next page showing 2 views of the heart. So here you can see the anterior view of the heart showing major vessels and the frontal section showing interior chambers and valves. This is a lot of information that perhaps you're not would quite understand based on what we've just talked about. This is a really great image showing you the intricacies that are involved in this organ. We'll learn this a little later in the lecture, but generally speaking, any vessels, so your arteries and veins, you see these vessels on the heart itself, if they're blue, it's carrying deoxygenated or oxygen poor, carbon dioxide rich blood. If it's red, it's carrying oxygenated blood. So it's just a good rule of thumb to remember. Better viewed on the last image, but still applicable to the image here on the left. The heart has 4 hollow cavities or chambers, 2 atria, singular form of that is atrium, and 2 ventricles. Each of these chambers is lined with endocardium, which helps blood flow smoothly through the heart. The superior atria are primarily receiving chambers. As a rule, they are not important in the pumping activity of the heart. Instead, they assist with filling of the ventricles. Blood flows into the atria under low pressure from the veins of the body and then continues on to fill the ventricles. The inferior thick-walled ventricles are the discharging chambers or actual pumps of the heart. When they contract, blood is propelled out of the heart and into the circulation. The right ventricle forms the heart's most anterior surface, and the left ventricle forms its apex. The septum that divides the heart longitudinally is referred to as the interatrial septum, where it divides the atria, and the interventricular septum, where it divides the ventricles. So while the heart is just a single organ, it does act as a double pump. arteries carry blood away from the heart and veins carry blood towards the heart. And the right side works as a pulmonary circuit pump, receiving that oxygen-poor blood, that blue blood, through the large superior vena cava and inferior vena cava, and pumps it out through the pulmonary trunk. The pulmonary trunk splits into the right and left pulmonary arteries, which carry blood to the lungs, where oxygen is picked up, carbon dioxide is unloaded. Oxygen-rich blood drains from the lungs and is returned to the left side of the heart through 4 pulmonary veins. This circuit from the right ventricle to the lungs and back to the left atrium receiving chamber is called the pulmonary circulation. So that's what you're looking at here on the left. Its only function is to carry blood to the lungs for gas exchange, so to bring oxygen into the blood and to unload that carbon dioxide and then return to the heart. So oxygen-rich blood returned to the left atrium flows into the left ventricle and is pumped out into the aorta. So the aorta is the big daddy boss artery from which the systemic arteries branch just by essentially every single body tissue. After oxygen is delivered to tissues, oxygen-poor blood circulates from the tissues back to the right atrium via the systemic veins, which finally empty their cargo into either the superior or inferior vena cava. This second circuit from the left ventricle through the body tissues and back to the right atrium is called systemic circulation. So the pulmonary circulation, systemic circulation. It supplies oxygen and nutrient-rich blood to all the organs. Because the left ventricle pumps blood over much of the longer systemic pathway through the body, its walls are substantially thicker, which you can see here on the right image, than those of the right ventricle, and it is a more powerful pump than the right ventricle. And you can see that muscular interventricular septum that's separating the 2 ventricles as well. So your heart is equipped with 4 valves which allow blood to flow in only one direction through the heart chambers, from the atria through the ventricles and out the great arteries leaving the heart. So the atrioventricular valves, AV valves, are located between atria and ventricles on each side. These valves prevent backflow into the atria when the ventricles contract. The left AV valve, the bicuspid valve, is also called the mitral valve, so unfortunately they all have several names. It consists of 2 flaps, so bicuspid, or cusps of endocardium. The right AV valve is the tricuspid valve, and as you guessed it, has 3 cusps, 3 flaps. Tiny white cords, the cordae tendinae, literally mean tendinous cords, sometimes colloquially called the heartstrings, anchor the cusps to the walls of the ventricles, and when the heart is relaxed, blood is passively filling the chambers. The AV valve cusps hang limply into the ventricles. As the ventricles contract, they press on the blood in their chambers, and the pressure inside the ventricles begins to rise, forcing those cusps upward and closing the valves. At this point, the cordae tendinae tighten and anchor the cusp in a closed position. If cusps were unanchored, they would blow upward into the atria, and then backflow of blood would happen, which we don't want. The second set of valves are called the semilunar valves. They're at the bases of the 2 large arteries leaving the ventricular chamber, so they're known as the pulmonary semilunar valve and the aortic semilunar valve. So each of these valves has 3 cups that fit tightly together when the valves are closed. When ventricles are contracting, forcing blood out of the heart, the cusps are forced open and flatten against the walls of the arteries by the tremendous force of rushing blood. So while the AV valves, when ventricles contract, they close because these are charged. These valves are associated with blood vessels that are bringing blood outside of the heart. When the ventricle contracts, these open. When ventricles relax, the blood begins to flow backward toward the heart, and the cusps fill with blood like a parachute filling with air, closing the valves. So this, again, maintains one-way blood flow and prevents arterial blood from re-entering the heart. They each operate at a different time. The AV valves are open during heart relaxation and closed when ventricles are contracting. Semilunar valves are closed during heart relaxation and are forced open when ventricles contract. Again, opposite. They force blood to continually move forward through the heart by opening and closing in response to pressure changes in the heart. And I'll talk about some of the homeostatic imbalances that might occur with that. Before I talk about some of the homeostatic imbalances, let's talk about cardiac circulation. So funny enough, while the heart is charged with oxygenating and nourishing the rest of the tissues in the body, the blood contained in the heart does not nourish the myocardium. The functional blood supply that oxygenates and nourishes the myocardium is provided by the right and left coronary arteries. So the coronary arteries branch from the base of the aorta and encircle the heart in the coronary sulcus, also called the atrioventricular groove, at the junction of the atria and ventricles. The coronary arteries and their major branches, anterior interventricular artery and circumflex artery on the left, and posterior interventricular artery and marginal artery on the right, are compressed. Flow is inhibited but not stopped completely when the ventricles are contracting, and fill when the heart is relaxed. The myocardium is drained by several cardiac veins which empty into a large vessel on the posterior of the heart called the coronary sinus. And then this just in turn empties right back into that right atrium, which is the first stop for unoxygenated or deoxygenated blood that's leaving the systemic circulation. So it ends up right where it needs to be. So a few homeostatic imbalances. We have pericarditis, which has to do with inflammation of the pericardium. So that lining around the heart. And then endocarditis, infection and inflammation of the endocardium. So this often happens because of repeated bacterial infections. It can cause issues with valves. So this infection or repeated infection of the endocardium can lead to valvular stenosis, where those cusps that are supposed to open and close become very stiff. So they become incompetent and don't close properly. So blood backflow will occur, which will cause a chain reaction in the functioning of the heart. The function is to get the deoxygenated blood to the lungs, back into the heart so that it can be pumped to the rest of the body. But if there's a bunch of backflow, you're not getting as much oxygen into the systemic circulation as you can. So sometimes a valve will have to be replaced depending on the severity of the valve's condition. So I talked about valvular stenosis, angina pectoris. So this is a fancy way of saying chest pain. It happens in situations in which that myocardium is deprived of oxygen. So sometimes it's intermittent, sometimes it is longer lasting, often associated with myocardial infarctions, which is just a fancy name for heart attack or coronary. And this is where the oxygen deprived cells that are causing that pain actually infarct and die. Relative to some of your other organs, your heart is pretty moderately sized, but it does a lot of work. It's making these continuous round trips. Well, the heart itself isn't, but it's causing the blood to make these continuous round trips around your body, and then back to the heart and then back out. So in a single day, the heart will push out the body supply of 6 quarts or so of blood through the blood vessels over 1,000 times. This means it actually pumps about 6,000 quarts of blood or 1,500 gallons every day. And this is just normal homeostatic living. So you can imagine if there's issues with heart functioning for any reason, how this can put a lot of stress on those tissues that need oxygen, which are all of them. So the heart is very important in your body's functioning. The intrinsic conduction system of the heart. So we learned that skeletal muscles are stimulated by nerve impulses, but cardiac muscles can and do contract spontaneously and independently, even if all nervous connections are severed. Spontaneous contractions occur in a regular and continuous way, ideally. Although cardiac muscle can beat independently, the muscle cells in different areas of the heart have different rhythms. So atrial cells beat about 60 times per minute, but ventricular cells contract more slowly, 20 to 40 times per minute. Therefore, without some kind of intrinsic unifying control system, the heart would be uncoordinated and inefficient at doing its job, which is being a pump. So there are two systems that regulate heart activity. One of these is, excuse me, the nerves of the autonomic nervous system, which act like brakes and gas pedals to decrease and increase the heart rate, depending on which division is activated. So autonomic, again, is your sympathetic division and your parasympathetic division. We'll talk about that a little later in the chapter. The second system is this intrinsic conduction system that you're looking at right here, or the nodal system. It's built into the heart tissue itself and sets its basic rhythm like a drummer sets the beat for a band playing a song, or a metronome for anybody that's done anything with music. It's composed of special tissue found nowhere else in the body. It's like a cross between muscle and nervous tissue. And this system causes the heart muscle depolarization only in one direction, from the atria to the ventricles. One of the most important parts of the intrinsic conduction system is a crescent-shaped node of tissue called the sinoatrial node, the SA node, located in the right atrium. You can see the top left of the photo. And other components include the atrioventricular node, the AV node, at the junction of the atria and the ventricles, and the AV bundle, or the bundle of His, and the right and left bundle branches. And finally, the Purkinje fibers, which spread within the myocardium of the ventricle walls. The SA node is a tiny mass of cells with a very important job, with a very big job. The fastest rate of depolarization in the whole system. It starts each heartbeat and sets the pace for the whole heart. So the SA node is known as the pacemaker. From the SA node, the impulse spreads through the atrial walls to the AV node, and then the atria contract. At the AV node, the impulse is delayed briefly to give the atria time to finish contracting, then passes rapidly through the AV bundle, the bundle branches, and the Purkinje fibers, resulting in a ringing contraction of the ventricles that begins at the heart apex and moves towards the atria. This contraction is what effectively ejects blood superiorly into the large arteries leaving the heart. So I think probably in our class meeting, we'll try to watch a video of this. It's probably going to be easier to understand. But know that the impulses start in the right atrium and move down and then branch out, so that we're having a consistent flow of contraction throughout the heart organ. Another pit stop to learn about some homeostatic imbalances. We have heart blocks, so there's different levels of heart block. So you can have partial or total block of that electrical conduction, so issues with SA node, AV node, Purkinje fibers, etc., causing the ventricles to beat at their own rate. Obviously, we've established that the atria and the ventricles are not experiencing all the same depolarization at the same time. They're not beating pretty much in this specific sequence. We're not getting a good contraction, therefore the heart is not acting as the most efficient pump. Ischemia is lack of adequate blood supply to the heart muscle, which can lead to many things, but one of them is fibrillation. So a rapid, uncoordinated quivering of the ventricles. So this would be ventricular fibrillation, which is considered a mortal heart rhythm. This prevents the heart from pumping any blood. So not great, and is a major cause of death. So this is why a lot of places, even here on campus, you'll see AEDs. Ventricular fibrillation is one of the shockable rhythms, and the hope is just to reset that electrical conduction so that we start to get a normal depolarization so the heart can start pumping blood out to the body again. Then tachycardia and bradycardia. So normal heart rate for an adult is considered 60 to 100 beats per minute. Anything over 100 beats per minute is considered tachycardia or high heart rate. Anything under 60 beats per minute is considered bradycardia, low heart rate. Cardiac cycle and heart sound. So in a healthy heart, the atria contract simultaneously. Then they start to relax and the ventricles begin to contract. Systole and diastole mean heart contraction and relaxation respectively. Because most of the pumping work is done by the ventricles, these terms refer to the contraction and relaxation of the ventricles unless otherwise stated. So the term cardiac cycle refers to the events of one complete heartbeat, during which both atria and ventricles contract and then relax. The average heartbeats approximately 75 times per minute, so the length of the cardiac cycle is normally about 0.8 seconds. And you can see here the breakdown of each step. So we'll talk through it here. So one, we have atrial diastole, ventricular filling. We'll begin with the heart completely relaxed. So the pressure in the heart is low, the AV valves are open. Remember, the AV valves remain open until the ventricle contracts and blood is flowing passively through the atria into the ventricle. And the semilunar valves are closed. Atrial systole, the ventricles remain in diastole, so relaxed, as the atria contract, forcing blood into the ventricles to complete ventricular filling. Isovolumetric contraction, atrial systole ends, and ventricular systole begins. The initial rise in intraventricular pressure closes the AV valves, preventing backflow of blood into the atria, and for a moment the ventricles are completely closed chambers. Ventricular systole, so this is where that volume gets ejected. The ventricle continues to contract, causing intraventricular pressure to surpass the pressure of the major arteries leaving the heart, causing the semilunar valves to open and blood to be ejected from the ventricles. During this phase, the atria are again relaxed and filling with blood, preparing for the next cycle. Isovolumetric relaxation. As ventricular diastole begins, the pressure in the ventricles fall below that in the major arteries, and the semilunar valves close to prevent backflow into the ventricles. For another moment, the ventricles are completely closed chambers, and the intraventricular pressure continues to decrease. Meanwhile, the atria have been filling in diastole. When the ventricular pressure falls below that of the atrial pressure, the AV valves open and the cycle repeats. When using a stethoscope to auscultate, you can hear two distinct sounds from each cardiac cycle. These heart sounds are often described by the syllables lub-dub or lub-dup. The sequence of the lub-dub, pause, and so on. The first heart sound lub is caused by the closing of the AV valves. And the second heart sound dub occurs when the semilunar valves close at the end of ventricular systole. The first heart sound is longer and louder, and the second heart sound, which tends to be short and sharp. So if you have a stethoscope at home and a healthy individual in the house, or perhaps you can try to listen to it on yourself, I encourage you to listen to this. And it's kind of cool that now you can, look at this image, look at these videos, look at this verbal explanation of what the sounds are, what valves are closing, so you know which, is it the atria or the ventricle that's filling, is it the atria or the ventricle that's contracting. It's pretty cool. So another homeostatic imbalance is heart murmurs. Heart murmurs, excuse me. These are abnormal, unusual heart sounds. So we have the lub dub, which are the normal heart sounds. But blood flows silently as long as the flow is smooth, uninterrupted. If it strikes some kind of obstruction, flow becomes turbulent and generates sounds that can be heard with a stethoscope. So they're common in young children and some elderly people with perfectly healthy hearts. This is probably because their heart walls are thin and vibrate. However, murmurs in patients do not fall into either of these groups, most often indicate some kind of valve problem. So that's where the noise is coming from. So, for example, if a valve does not close tightly, it's considered incompetent. A swishing sound will be heard as the blood flows back through the partially open valve after the valve was supposed to be closed. Distinct sounds also can be heard when blood flows turbulently through stenosed narrowed valves. Again, let's talk about cardiac output. So we've already established that while the heart is the hub of the cardiovascular system, the blood it's pumping out is pretty important. So cardiac output is the amount of blood pumped out by each side of the heart, each ventricle, in 1 minute. And it's calculated by heart rate times stroke volume. Stroke volume is the volume of blood pumped out by a ventricle with each heartbeat. Increases as the force of ventricular contraction increases. Cardiac output varies with the demands of the body. It rises as stroke volume is increased and when heart rate increases, or both, right? Because it's heart rate times stroke volume. So if either of those factors increase, cardiac output will increase. So the normal adult blood volume is 6,000 milliliters. So nearly the entire blood supply passes through the body once each minute. Cardiac output varies, like we said, with the demands of the body. And we will take a look at the regulation of stroke volume here on the next slide. The regulation of stroke volume. So a healthy heart pumps out about 60% of the blood in its ventricles. So you're never going to see, we call it ejection fraction, which is the percentage of blood leaving the ventricle at 100%. Some blood is always retained in the heart, but 60% is where we want to see that. So it's about 70 mLs or 2 ounces. Stroke, so there's something called the Frank-Starling law of the heart. And it states that the critical factor controlling stroke volume is how much the cardiac muscle cells are stretched by the filling of the chambers just before they contract. And this is called preload. The more the muscle cells are stretched, the stronger the contraction, the higher the stroke volume. Two things influence preload: the amount of venous return, so blood returning to the heart, and the length of time the ventricles are relaxed and filling, determined by the heart rate. Anything that increases the volume or speed of venous return also increases stroke volume and force of contraction. For example, a slow heartbeat allows more time for the ventricles to fill, while exercise speeds venous return because it results in increased heart rate and force. The enhanced squeezing action of active skeletal muscles on the veins helps return blood to the heart, which we'll talk about that further on in the lecture. And this so-called muscular pump also plays a major role in increasing the venous return. In contrast, low venous return, such that might result from blood loss or abnormally rapid heart rate, decreases stroke volume. Contractility is the ability of the cardiac muscle to generate tension. Contractility is influenced by factors other than stretch, including the amount of calcium ions present. So there's that pesky calcium. Sympathetic nervous system stimulation and hormones such as epinephrine and thyroxine. As contractility increases, stroke volume increases. An afterload is the amount of pressure that the ventricles must overcome to eject blood. So it's determined by the blood pressure in the pulmonary trunk and in the aorta, pressing back on those semilunar valves. In order to pump blood, the ventricles must generate a force greater than the afterload, and if afterload increases, it will be more difficult for the ventricles to pump blood, and stroke volume will decrease. So that other factor contributing to cardiac output is heart rate. So let's talk about some of the factors that might modify basic heart rate. So in healthy people, stroke volume tends to be relatively consistent. When blood volume drops suddenly or when the heart has been seriously weakened, stroke volume of course declines, and then cardiac output is maintained by a quicker heartbeat. It compensates. Although heart contraction does not depend on the nervous system, its rate can be changed temporarily by the autonomic nerves. Indeed, the most important external influence on heart rate is the activity of the autonomic nervous system. There are several chemicals, hormones, and ions that can also modify heart rate. And let's talk a little bit more about, first we'll talk about neural, so those autonomic nervous system controls. So during times of that physical or emotional stress or perceived physical or emotional stress, the nerves of the sympathetic division of the autonomic nervous system more strongly stimulate the SA and AB nodes and the cardiac muscle itself. As a result, the heart will beat more rapidly. This is a familiar phenomenon to anyone who's ever been frightened or has had to run to catch a bus. As fast as the heart pumps under ordinary conditions, it really speeds up when special demands are placed on it. Because a faster blood flow increases the rate at which fresh blood cells reach body cells, more oxygen and glucose are made available to them during periods of stress. When demand declines, the heart will adjust accordingly. Parasympathetic nerves, primarily those vagus nerve fibers, slow and steady the rate, giving it more time to rest during those non-crisis times. So there are the neural controls of the sympathetic division and parasympathetic division. Hormones and ions. So various hormones and ions can have a dramatic effect on heart activity. Both epinephrine, which mimics the sympathetic nervous system, and thyroxine, a thyroid hormone, will increase heart rate and contractility. Excuse me. Electrolyte imbalances pose a real threat to the heart. For example, recall calcium ions are required for muscle contraction, and the cardiac muscle is a muscle. A reduced level of ionic calcium in the blood depresses the heartbeat, whereas excessive levels of blood calcium ions cause such prolonged contractions that the heart may stop entirely. It's a big problem. So either excess or lack of needed ions such as sodium and potassium also modify heart activity. A deficit of potassium ions in the blood, for example, will cause the heart to beat feebly and abnormal heart rhythms will occur. And then physical factors. So physical factors like age, gender, exercise, body temperature. The resting heart rate of a fetus is about 140 to 160 beats per minute, and then this will gradually decrease throughout life. Average adult heart rate in a female is about 72 to 80 beats per minute, and in a male, 64 to 72. Of course, there are mitigating factors to that, like cardiovascular health, training, etc. Heat increases heart rate by boosting metabolic rate of heart cells. This explains the rapid pounding heartbeat you feel when you have a high fever, and accounts in part to the effect of exercise on heart rate because those working muscles are generating heat. Cold has the opposite effect. It directly decreases heart rate. As noted previously, exercise acts through the nervous system controls, sympathetic division, to increase heart rate, and also through the action of the muscular pump to increase stroke volume. Again, we'll talk a little bit more about that muscular pump later on in the lecture. So this diagram is just a representation to show you different things that influence cardiac output. So the keys to the bottom left, you can see some things increase or stimulate, reduce or inhibit. Initial stimulus will be, or stimuli rather, will be in the red boxes, and physiological response will be in the green boxes, with the end result being cardiac output. So crisis stressors and low blood pressure stimulate the sympathetic nervous system, which then stimulates increased contractile force of the cardiac muscle and increases the heart rate, which then stimulates cardiac output. Crisis passes, and then the parasympathetic nervous system is stimulated, which reduces the heart rate, which decreases cardiac output. High blood pressure, blood volume will inhibit that parasympathetic, or that sympathetic nervous system rather. Exercise will stimulate the activation of the skeletal muscle and respiratory pumps, which again we will learn about further on in the lecture, which will increase venous return, increasing stroke volume, increasing cardiac output. decreased blood volume from something like a hemorrhage, so severe rapid blood loss, will inhibit venous return, which will inhibit stroke volume, which will decrease cardiac output. Another homeostatic imbalances pit stop. So congestive heart failure, CHF. The pumping action of a healthy heart maintains a balance between cardiac output and venous return. But when the pumping efficiency of the heart is reduced so that the circulation isn't adequate to meet tissue needs, this is congestive heart failure. It's usually a progressive condition that reflects weakening of the heart by coronary atherosclerosis, which is a clogging of the coronary vessels with fatty buildup, hypertensive heart disease, or multiple myocardial infarctions. So repaired with non-contracting scar tissue. So remember, myocardial infarctions are heart attacks. In these patients, the heart pumps weakly and is nearly worn out. So it's just tired. The weak contractions of a heart in congestive heart failure result in lower stroke volume. For those patients, a drug called digitalis is routinely prescribed because it enhances contractility and increases stroke volume of the heart, resulting in that increased greater cardiac output. Because the heart is a double pump, each side can fail independently of the other. If the left heart fails, so left-sided heart failure, pulmonary congestion occurs. The right side of the heart continues to propel blood to the lungs, but the left side is unable to eject the returning blood into the systemic circulation. So as a result, blood will back up into the lungs. They become swollen with blood, and the pressure within them increases, and fluid will leak into the lung tissue, causing pulmonary edema. So this can cause really serious problems. This can cause a person who is untreated to essentially drown in these fluids. If the right side of the heart fails, so right-sided heart failure, peripheral congestion occurs as the blood will back up into the systemic circulation. Edema is the most noticeable, so swelling of the tissues is most noticeable in the distal parts of the body. You see this in the feet, the ankles, the fingers, they become puffy and swollen. Failure of one side of the heart puts a greater strain on the opposite side, and eventually the whole heart can fail. So this is something that is important to diagnose and begin to treat effectively, because like it says, even if it's only one-sided heart failure, it can essentially overwork the other side of the heart until both sides fail. Now let's talk about the vascular system. So this is just referring to the system in which the blood circulates in after it leaves the heart. So as the heart beats, that blood in the left ventricle is propelled into large arteries leaving the heart. As the large arteries branch, blood moves into successively, smaller and smaller arteries, and then into arterioles, which are just smaller arteries, which feed the capillaries in the tissue. So capillaries are even smaller blood vessels connecting arterioles and the venules, which we'll talk about here shortly. But capillaries are the site of exchange between blood and interstitial fluid. Clusters of capillaries called capillary beds are drained by venules, which are small veins, which in turn empty into veins that merge and finally empty into the great veins, the vena cava, that go back to the heart to get reoxygenated. So arteries carry blood away from the heart, and veins drain tissues and return the blood to the heart. Only the tiny hair-like capillaries, which extend and branch to the tissues and connect the smallest arteries, the arterioles, to the smallest veins, the venules, directly serve the needs of the body cells. It's important to note, so we've established that arteries leave the heart. So you know when blood is leaving the heart, it is oxygenated. When it is going back to the heart via veins, it is deoxygenated, oxygen poor. So in most diagrams, which we kind of learned in past lectures, in most diagrams, oxygenated blood is indicated by red. So oxygen rich is red, and oxygen depleted blood or carbon dioxide rich blood is indicated by blue, with a few exceptions. So for instance, we have seen that oxygen poor blood is carried in the pulmonary trunk, which isn't actually an artery, while oxygen rich blood is transported back to the heart in pulmonary veins. An easy way to remember the difference is the following: arteries are red and veins are blue, but for the lungs there's an exception of 2. Let's look a little bit at the microscopic anatomy of blood vessels. So except for microscopic capillaries, which only have 1 layer, which we'll talk about on the next slide, the walls of blood vessels have 3 layers or tunics. The tunica intima, which lines the lumen or interior of the vessel, so intimate, intima, the closest to the interior, is a thin layer of endothelium, squamous epithelial cells resting on the basement membrane. Its cells fit closely together and form a slick surface that decreases friction as blood flows through the vessel lumen. The tunica media is the bulky middle layer, made up mostly of smooth muscle and elastic fibers. Some of the larger arteries have an elastic lamina, sheets of elastic tissue in addition to scattered elastic fibers. The smooth muscle, which is controlled by the sympathetic nervous system, is active in changing the diameter of the vessels. As the vessels constrict or dilate, blood pressure increases or decreases respectively. And then the tunica externa, so external, it's the outermost tunic. This layer is composed largely of fibrous connective tissues. You can see there are the differences between the arteries and the veins, which we'll get more into in the next slide. And that has to do with their function. And you can see at the top right, even the thickness of, some of these tunics between the artery and the veins and the difference. And when you think about what their function is, it makes sense. As I said, let's talk about some of the structural differences in arteries, veins, and capillaries. So as you saw in the microscopic image on the last slide, the walls of arteries are usually much thicker than veins. So thicker tunica media, so that smooth muscle layer in the middle. Lumens of veins tend to be much larger than those of corresponding arteries, having a thicker tunica externa. The structural difference is related to a difference in function. So arteries carry blood away from the heart, and they must be able to expand and stretch as the blood is forced into them, and then recoil passively as the blood flows off into the circulation during diastole. Their walls must be strong and stretchy enough to take these continuous changes in pressure without stretching out permanently. Because the blood pressure in veins is usually too low to force the blood back to the heart, and because blood returning to the heart often flows against gravity, like the blood that has to come back from your lower extremities, veins are modified to ensure that the amount of blood returning to the heart equals the amount being pumped out of the heart at any time. The lumens of veins, like I said, tend to be much larger than their corresponding arteries, and they tend to have thinner tunica media, but a thicker tunica externa. The large veins have valves to prevent backflow, like those in the heart. Muscular pumps and the respiratory pump also enhance venous return. So skeletal muscle activity, known as the muscular pump, enhances venous return because as the muscles surrounding the veins contract and relax, blood is squeezed or milked through the veins towards the heart. So you can see why something like being sedentary, sitting still for a long time, could put somebody at higher risk for blood clots. Finally, the drop in pressure that occurs in the thorax just before we inhale causes the large veins near the heart to fill, and thus the respiratory pump also helps return blood to the heart. There are special capillary beds found in the mesenteries. So in general, the transparent walls of the capillaries are only one cell layer thick, which, like I said before, is just the tunica intima. Because of this exceptional thinness, this is where exchange happens between the blood and tissue cells. The tiny capillaries tend to form interweaving capillary beds, and the flow of blood from an arteriole to a venule, that is, through a capillary bed, is called microcirculation. In most body regions, a terminal arteriole branches into 10 to 20 capillaries, the exchange vessels, which drain into a postcapillary venule. So a tiny artery to a tiny vein. Blood flow in the capillary bed is controlled by the level of constriction in the terminal arteriole and other arterioles feeding into it. If the terminal arteriole is dilated, blood enters the capillary bed, exchange occurs. If the terminal arteriole is constricted, no blood flows through the capillary bed. So the special capillary beds found in the mesenteries, which the mesenteries are the serous membranes holding the intestines in place. They have precapillary sphincters, which regulate blood flow in the capillary bed and a vascular shunt, which we'll see in an image on the next slide. A vascular shunt is a vessel that directly connects the arteriole and the venule at opposite ends of the bed. When the precapillary sphincters are relaxed and open, blood flows through the capillaries and takes part in exchange with cells. When the sphincters are contracted, blood flows through the shunt and bypasses cells in that region. So on the left here, what we're looking at is an example of a muscular pump. So when the skeletal muscle contracts and presses against that flexible vein, the valves proximal to the area are contracted or are forced open. So the valves proximal to the area of contraction, are forced open, and blood is squeezed towards the heart like toothpaste from a tube. The valves distal to the point of contraction are closed by backflowing blood to prevent that backflow. And then on the right, we're looking at the different capillary beds. So in A, you see that the arteriole is on the left, the venule is on the right, arteriole is dilated. If you look at the top of that, you can see that it's nice and open, so blood flow is happening, exchange is happening in that capillary bed. Arterioles become constricted so that the arteriole, that tiny artery, becomes smaller. No exchange is happening in the capillary bed, so there's no exchange happening between the terminal arteriole and the postcapillary venule. And then we have that special mesenteric, where even though um, blood flow or exchange might not be happening in the whole capillary bed, it can happen via the sphincters and the vascular shunt. So the vascular shunt bypasses the capillaries when the precapillary sphincters controlling blood entry into the capillaries are constricted. Another homeostatic imbalance pit stop. So we have varicose veins, which are common in people who stand for long periods of time, and obese or pregnant individuals. So common factors include blood pooling in the feet and legs and being inefficient in returning, resulting from inactivity or pressure on the veins. For pregnant women, that increased fluid in the body would cause this pressure on the veins. Thrombophlebitis is a serious complication of varicose veins. It's inflammation of a vein that results when a clot forms, thrombo, in a vessel with poor circulation, and this clot can then detach and become an embolism or an embolus, and it can cause a pulmonary embolus. So pulmonary being your lungs, this is a life-threatening condition in which the embolism lodges in a vessel of the lung. Major arteries of the systemic circulation. So the aorta. The aorta, you can see just up superior to the heart is the aortic arch. If you follow that down, then we have the abdominal aorta. It's the largest artery of the body. In adults, the aorta is about the size of a garden hose, so with an internal diameter about equal to the diameter of your thumb. So it's pretty thick. Where it leaves the left ventricle of the heart, it decreases only slightly in diameter as it runs to its terminus. Different parts of the aorta are named for either their location or their shape. So the aorta springs upward from the left ventricle of the heart as the ascending aorta, arches to the left as the aortic arch, and then plunges downward through the thorax, following the spine, like I said, the thoracic aorta, finally to pass through the diaphragm into the abdominal pelvic cavity, where it is the abdominal aorta. The major branches of the aorta and the organs they serve are listed next. I will tell you them in sequence, and you can kind of follow along on the photo. As you locate arteries on the figure, use what you already know about to make your learning easier. In many cases, the name of arteries tells you what body regions or organs are being served. So the arterial branches of the ascending aorta, we have the right coronary artery and the left coronary artery. So we know that this is how the heart muscle itself gets its oxygen. The arterial branches of the aortic arch. The brachiocephalic trunk is the first branch off the aortic arch, splits into the right common carotid artery, which further splits into a right internal and right external carotid arteries, and the right subclavian artery. Then we have the left common carotid, the second branch off the aortic arch, divides, forming the left internal carotid, which serves the brain, and the left external carotid, which serves the skin and muscles of the head and neck. The third branch off the arch is the left subclavian artery. Gives off an important branch, the vertebral artery, which serves part of the brain, vertebral. In the axilla, the subclavian artery becomes the axillary artery and then continues into the arm as the brachial artery, which supplies the arm at the elbow. The brachial artery splits to form the radial artery and the ulnar artery, which serve the forearm. The intercostal arteries, these are the arterial branches of the thoracic aorta. There's 10 pairs, and they supply the muscles of the thorax wall. Other branches of the thoracic aorta supply the lungs, the bronchial arteries, and the esophagus, the esophageal arteries, and the diaphragm, the phrenic arteries. These arteries that I just listed in the thoracic aorta aren't actually in the picture here. Next, we have the arterial branches of the abdominal aorta. We have the celiac trunk. So this is just inferior to the diaphragm. It's the first branch of the abdominal aorta. It is a single vessel that has 3 branches: the left gastric artery, which supplies the stomach, the splenic artery, which supplies the spleen, and the common hepatic artery, which supplies the liver. The unpaired superior mesenteric artery supplies most of the small intestine and the first half of the large intestine. The renal arteries, right and left, serve the kidneys. The gonadal, right and left arteries supply the gonads. The lumbar arteries, not illustrated in this photo, are several pairs of arteries serving the heavy muscle of the abdomen and trunk walls. The inferior mesenteric artery is a small unpaired artery supplying the second half of the large intestine. The common iliac, right and left, are the final branches of the abdominal aorta. Each divides into the internal iliac artery, which supplies the pelvic organs, so like your bladder, rectum, and so on, and the external iliac artery, which enters the thigh where it becomes the femoral artery. The femoral artery and its branch, the deep artery of the thigh, serve the thigh. At the knee, the femoral artery becomes the popliteal artery, and then splits into the anterior tibial artery and the posterior tibial artery, which then supply the leg and foot. The anterior tibial artery terminates in the dorsalis pedis artery, which via the arcuate artery supplies the dorsum of the foot. Dorsalis pedis is often palpated in patients with circulatory problems of the legs to determine whether the distal part of the leg has adequate circulation. So you can recognize that you palpate a pulse in some of these places. So the radial artery, for example, and that's what you're feeling is the beat of the heart in that artery. The blood pumping through that artery as the heart beats. Now let's chat about some of the major veins of the systemic circulation. So remember, arteries are what's bringing the blood away from the heart, oxygenating the body, and veins bring all of that blood back. Although arteries are generally located in deep, well-protected body areas, many veins are more superficial, easily seen and palpated on the body surface. Most deep veins follow the course of major arteries, and with few exceptions, the naming of these veins are basically identical to their companion arteries. Major systemic arteries branch off the aorta, whereas the veins converge on the vena cava, which enter the right atrium of the heart. Veins draining the head and arms empty into the superior vena cava, and those draining the lower body into the inferior vena cava. So veins draining into the superior vena cava. These are listed distal to proximal. That is the same direction that the blood flows into the superior vena cava. Excuse me. The radial vein and ulnar vein, which deep veins of the forearm, unite to form the brachial vein, which then turns into the axillary vein in the axillary region. The cephalic vein provides for superficial drainage of the lateral aspect of the arm and empties into the axillary vein. The basilic vein is a superficial vein that drains into the medial aspect of the arm and empties into this brachial vein proximally. The basilic and cephalic veins are joined at the anterior aspect of the elbow by the median cubital vein. It's often chosen as a site for withdrawing blood for the purpose of blood testing. The subclavian vein receives venous blood from the arm through the axillary vein and from the skin and muscles of the head through the external jugular. The vertebral vein drains the posterior part of the head. The internal jugular vein drains the dural sinuses of the brain. And the brachiocephalic right and left veins are large veins that receive venous drainage from the subclavian, vertebral, and internal jugular veins on each side.
The brachiocephalic veins join to form the superior vena cava, which enters the heart. The azygos vein, not illustrated in this photo, is a single vein that drains the thorax and enters the superior vena cava, but just before it joins the heart. Veins draining into the inferior vena cava. The anterior tibial and posterior tibial vein and the fibular vein drain the leg, so your calf and foot. Fibular vein isn't shown here. The posterior tibial vein becomes the popliteal vein at the knee, the femoral vein at the thigh, and the femoral vein becomes the external iliac vein as it enters the pelvis. The great saphenous veins are the longest veins in the body. They receive superficial drainage of the leg. They begin at the dorsal venous arch in the foot, travel up the medial aspect of the leg to the empty in the femoral vein in the thigh. Each common iliac, so right and left vein, is formed by the union of the external iliac vein and the internal iliac vein, which drains the pelvis on its own side. And the common iliac veins join to form the inferior vena cava, which then ascends superiorly to the abdominal cavity. The right gonadal vein drains the right ovary in females, right testicle in males. The left gonadal vein empties the left renal vein superiorly. The gonadal veins are not illustrated here. The renal right and left veins drain the kidneys. The hepatic portal vein is the single vein that drains the digestive tract organs and carries the blood through the liver before it enters the systemic circulation. We'll talk about hepatic portal circulation in the next section. And then the right and left hepatic veins drain the liver. The arterial supply of the brain. So because of lack of blood for even a few minutes causes delicate brain cells to die, a continuous blood supply to the brain is crucial. The brain is supplied by two pairs of arteries, the internal carotids and the vertebral arteries. The internal carotid arteries are branches of the common carotid arteries and run through the neck and enter the skull through the temporal bone. Once inside the cranium, each divides into the anterior cerebral artery and middle cerebral artery. So ACA, MCA, which supply most of the cerebrum. The paired vertebral arteries pass upwards from the subclavian arteries at the base of the neck. Within the skull, the vertebral arteries join to form a single basilar artery. This artery serves the brainstem and cerebellum as it travels upwards. At the base of the cerebrum, the basilar artery divides to form the posterior cerebral arteries, which supply the posterior part of the cerebrum. The anterior and posterior blood supplies of the brain are united by small communicating arterial branches. The result is a complete circle of connecting blood vessels called the cerebral arterial circle or the circle of Willis, which surrounds the base of the brain. The cerebral arterial circle protects the brain by providing more than one route for blood to reach the brain tissue in case of a clot or impaired blood flow anywhere in the system. So what you're seeing in A is just the major arteries of the brain. The four arteries composing the circle of Willis are indicated by the bullet points. So you have anterior communicating artery, ACA, anterior cerebral artery, posterior communicating artery, posterior cerebral artery. And then in B, we're looking at a colorized arteriograph of the brain's arteries. Now let's look at the hepatic portal system and circulation. So the veins of the hepatic portal circulation drain digestive organs, the spleen, the pancreas, and deliver blood to the liver through the hepatic portal vein. When you have just eaten, the hepatic portal blood contains large amounts of nutrients because the liver is a key body organ involved in maintaining the proper glucose, fat, and protein concentrations in the blood. The system allows blood to take a detour to ensure that the liver processes these substances before they enter the systemic circulation. The liver also helps to detoxify blood by removing and processing toxins absorbed by the stomach and intestines. As blood flows slowly through the liver, some of the nutrients are removed to be stored and processed in various ways for later release in the blood. The liver is drained by the hepatic veins that enter the inferior vena cava. The major vessels composing the hepatic portal circulation, which you can see in the right image here, include the inferior and superior mesenteric arteries, the splenic vein, and the left gastric vein. The inferior mesenteric vein, draining the terminal part of the large intestines, drains into the splenic vein, which itself drains the spleen, pancreas, and left side of the stomach. The splenic vein and superior mesenteric artery, which drains the small intestines and first part of the colon, join to form the hepatic portal vein. The left gastric vein, which drains the right side of the stomach, drains directly into the hepatic portal vein. And on the left here, note the presence of 2 capillary beds within the hepatic portal system. Nutrients and toxins picked up from the capillaries in the stomach and intestines are transported to the liver for processing, and from the liver, the blood continues into the hepatic veins and inferior vena cava. So let's talk a little bit more about things like arterial pulse. We'll talk about blood pressure on the next slide, but in general, along with things like respiratory rate and body temperature, things like pulse and blood pressure are considered your vital signs in a clinical setting. So first, arterial pulse. So the alternating expansion and recoil of those arteries that occur with each beat, each contraction of the left ventricle, create a pressure wave, which is the pulse. Normally, the pulse rate equals the heart rate. So pulse averages 70 to 76 beats per minute in a healthy resting person. 60 to 100 is permissible. It's influenced by activity, postural changes, and emotions. You can feel pulse in any artery lying close to the body surface by compressing the artery against firm tissue. This provides an easy way at counting heart rate. Because the same points are compressed to stop blood flow into distal tissues during significant blood loss or hemorrhage, they're also called pressure points. So let's look at the pulses on this gentleman and see if you can't feel them on yourselves. So we have the superficial temporal artery, the facial artery, common carotid. Never compress your bilateral carotids at the same time or on a patient. You can make somebody pass out that way. I'm sure some of you already know. Brachial artery is right there at the crook of the elbow and the antecubital fossa. Radial artery is the one we commonly check on the wrist, thumb side of the wrist. Femoral artery is in the groin. This one is commonly used when we're carotid and femoral arteries are commonly used if you're in a code blue situation. Popliteal artery is a little more difficult to feel. It's behind the knee. Posterior tibial artery is just posterior to the tibia and kind of behind that medial malleolus, that middle ankle bone. And then dorsalis pedis is right there on top of the foot. This is where, if we were in an in-person class setting, this would be a really good opportunity for me to show you how to palpate these pulses. So just know a pretty good trick, I would say, would be to compress down a little harder at first and then slowly release to palpate that pulse. So you can do it in your wrist. You first press down harder and then slowly release. And what that pressing down harder is, you're compressing it a little bit, letting some blood build up behind it, so that first beat to help you locate it will be a little stronger. So blood pressure is just the pressure the blood exerts against the inner walls of the blood vessels, and it is the force that keeps blood circulating continuously, even between heartbeats. So any system equipped with a pump that forces fluid through a one-way network of closed tubes operates under pressure. In our discussions, blood pressure is understood to mean the pressure that within the large systemic arteries near the heart. Blood pressure gradient. So when the ventricles contract, they force blood into large, thick-walled elastic arteries close to the heart that expand as the blood is pushed into them. The high pressure in these elastic arteries forces the blood to continuously move into areas of lower pressure, so it moves on a pressure gradient. The pressure is highest in the large arteries closest to the heart and continues to drop through the systemic pathway, reaching 0 at the right atrium. Recall that blood flows into the smaller arteries, then arterioles, then capillaries, venules, then veins, and then back into the large vena cava, entering the right atrium. It flows continuously along a pressure gradient, from high to low pressure, as it makes its circuit day in and day out. The valves in the large veins, the milking activity of skeletal muscles, the pressure changes in the thorax are important because together they ensure blood flows back into the heart to then be pumped out again, to be oxygenated and then pumped out again. The pressure differences between the arteries and veins become very clear when the vessels are cut. If a vein is cut, the blood flows evenly from the wound. A lacerated artery produces rapid spurts of blood. A similar pressure drop occurs as blood flows through the pulmonary pathway. Continuous blood flow absolutely depends on the stretchiness of the larger arteries and their ability to recoil and keep exerting pressure on the blood as it flows into the rest of the vascular system. Think of a garden hose with relatively hard walls. When the water is turned on, the water spurts out under high pressure because the hose walls don't expand. However, when the water faucet is suddenly turned off, the flow of the water stops just as abruptly. The reason that the walls of the hose cannot recoil to keep pressure on the water, therefore the pressure drops and the flow of water stops. The importance of the elasticity of the arteries is best appreciated when it is lost, as happens in things like arteriosclerosis, aka hardening of the arteries. The early stage of arteriosclerosis is atherosclerosis, so changes in the walls of large arteries consisting of lipid deposits on the artery walls, and this is again the early stage of arteriosclerosis and increasing rigidity of those larger arteries. So we talked about how to palpate a pulse. Now let's talk about how we measure blood pressure. So the off and on flow of blood into the arteries as the heart alternately contracts and relaxes causes the blood pressure to rise and fall during each beat. Thus, two arterial blood pressures are usually measured: systolic pressure, the pressures in the arteries at the peak of ventricular contraction, and diastolic pressure, so the pressure when the ventricles are relaxing. So systole, diastole. Systole is contraction, diastole is relaxation. So this is systole is the top number of your blood pressure, and diastolic is the bottom number of your blood pressure. Blood pressures are reported in millimeters of mercury, with higher systolic pressure written first. Most often, systemic arterial blood pressure is measured indirectly by oscillatory method. So that's as this outlines here. So the course of the brachial artery of the arm, assume a blood pressure of 120/70 in a young healthy person. So you palpate where the brachial artery is to find correct placement for your cuff, which is wrapped snugly around the arm just above the elbow, about 2 fingers width above the elbow, and inflated until the cuff pressure exceeds the systolic blood pressure. So this is your assumptions: 120. Generally, you'll pump it up to at least 160. At this point, the blood flow in the arm is stopped and the brachial pulse cannot be felt or heard. So actually at step 2, before you start inflating the cuff, you would already have your stethoscope placed. The pressure in the cuff is gradually reduced while the examiner listens or auscultates for the sounds of the brachial artery with the stethoscope. The pressure read is the first soft tapping sounds, so the first sound and the last sound. So I don't know if any of you have taken a blood pressure, but sometimes there can be a lot of extra noise, so you have to get really good at listening to what the sound of the artery is. And then as the pressure is reduced still further, the sounds become louder and more distinct, and when the artery is no longer constricted, the blood flows freely. The sounds can no longer be heard. So the pressure at which the sound disappears is the diastolic pressure. So some people get confused at those in-between beats. Those in-between beats are normal, but it's just the first beat you hear and the last beat you hear, and those are your numbers. So the effects of various factors on blood pressure. So arterial blood pressure is directly related to cardiac output and peripheral resistance. The relationship is expressed by this equation: blood pressure equals cardiac output times peripheral resistance. Peripheral resistance is the amount of friction or resistance to flow the blood encounters as it flows through the blood vessels. Many factors can increase this. but probably the most important is constriction or narrowing of the blood vessels, especially the arterioles, as a result of either sympathetic nervous system activity or atherosclerosis. Increased blood volume and increased blood thickness can also increase peripheral resistance. Any factor increasing either cardiac output or peripheral resistance causes an almost immediate rise in blood pressure. Many factors can alter blood pressure: age, weight, time of day, exercise, body position, emotional state, various drugs. The influence of a few of these factors is what we're going to further discuss here. So neural factors, so the autonomic nervous system, again, parasympathetic versus sympathetic. So the parasympathetic division has little to no effect on blood pressure, but the sympathetic division is important. And the major action that it takes is that it causes vasoconstriction. So it narrows the blood vessels, therefore increasing the peripheral resistance and therefore increasing the blood pressure. The sympathetic center and the medulla oblongata of the brain is activated to cause vasoconstriction in many different circumstances. For example, when we stand up suddenly after lying down, gravity causes blood to pool very briefly in the vessels of our legs and feet, and blood pressure will drop. This activates pressoceptors, also called baroreceptors, in the large arteries of the neck and chest, and they send off warning signals that result in a reflexive vasoconstriction, quickly increasing blood pressure back to the homeostatic level. When blood volume suddenly decreases, as in a hemorrhage, blood pressure will drop and the heart begins to beat more rapidly to try to compensate by circulating the remaining blood more quickly, that remaining oxygen more quickly. However, because blood reduces venous return, the heart also beats weakly and inefficiently. In such cases, the sympathetic nervous system causes vasoconstriction to increase blood pressure so that venous return increases and circulation can continue. This can also happen during severe dehydration. Another example is when we exercise vigorously, or we are get really, really scared and have to get away from a situation. The vessels of the skeletal muscle dilate to increase blood flow to the working muscles. And however, note that the sympathetic nerves never cause vasoconstriction of blood vessels of the heart or brain, which is important. There are renal factors as well. The kidneys play a major role in regulating arterial blood pressure by altering blood volume. As blood pressure or blood volume increases above normal, the kidneys allow more water to leave the body in the urine. Because the source of this water is the bloodstream, blood volume decreases, which in turn decreases blood pressure. However, when arterial blood pressure falls, the kidneys retain body water, maintaining blood volume and blood pressure. In order to increase blood volume and blood pressure, fluids might be ingested or might need to be administered via IV. In addition, when arterial blood pressure is low, certain kidney cells release the enzyme renin, which we've talked about, into the blood. Renin triggers a series of chemical reactions that result in the formation of angiotensin II, a potent vasoconstrictor chemical. Angiotensin also stimulates the adrenal cortex to release aldosterone, which we had learned about, a hormone that enhances sodium ion reabsorption by the kidneys. As sodium ions move into the blood, water follows. Thus, blood volume and blood pressure both rise in response to that aldosterone. Temperature in general, cold is vasoconstricting, and heat is vasodilating. So vasoconstricting, making the vessels smaller; vasodilating, making the vessels bigger. Chemicals, the effects of chemical substances, many which of our drugs on blood pressure, are widespread and well known in many cases. So we have epinephrine, which increases both heart rate and blood pressure; nicotine, which increases blood pressure by causing vasoconstriction; alcohol and histamine, which both cause vasodilation and decrease blood pressure. And this is the reason why a person who has had a lot of alcoholic beverages will sometimes become very flushed, because the alcohol is dilating those blood vessels in their skin or close to their skin surface. And diet. So although medical opinions tend to change and are at odds from time to time, it is generally thought that a diet low in salt, saturated fats, and cholesterol helps prevent hypertension or high blood pressure. There are several videos in your e-learning or your ebook rather, so we might take a look at some of those during our main lecture. Variations in blood pressure. So for normal adults at rest, 110 to about 140 systolic and 70 to 80 diastolic. Just for our knowledge purposes, there are many other standards and guidelines that are not necessary for this course. Normal will vary from person to person, so some people will run a little lower, a little higher outside of these predetermined standards of quote-unquote normal. Hypotension is low blood pressure and some homeostatic imbalances. So orthostatic hypotension is just temporary hypotension due to abrupt movement from sitting or reclining position to upright position. So this is kind of like your sympathetic nervous system is lagging a little bit, not sending those baroreceptors to constrict, and people get lightheaded and sometimes fall. This happens very often in elderly people. Circulatory shock, a condition where blood vessels are not adequately filled and circulation cannot continue normally. It can hint, so this can happen as a result of a few different things. It can happen usually because of blood loss. There's not enough blood to fill the vessels. And then we have hypertension. So this is just the designation, the medical diagnosis associated with somebody who has generally at least on three separate occasions had these high blood pressure readings. And then we have primary essential hypertension. This is hypertension that can't really be attributed to a specific cause. Sometimes there's not a distinct anatomical pathology, but they do recognize that factors like diet, obesity, heredity, race, and stress do seem to be players. Capillary exchange of gas and nutrients. So we've talked about how capillaries form the network that feeds the body's cells. So no substance has to diffuse very far to enter a Leber cell. The substances to be exchanged diffuse through the interstitial fluid between the cells. Substances tend to move to and from body cells according to their concentration gradients. Thus, oxygen and nutrients leave the blood and move into the cells, and carbon dioxide and other waste exit the cells and enter the blood. Basically, substances entering and leaving the blood may take one of four routes across the plasma membranes of the single layer endothelial cells forming the capillary wall, the tunica intima. So one, we have direct diffusion through membrane. So as with all cells, substances can diffuse directly through or across their plasma membranes if the substances are lipid soluble, respiratory gases, oxygen, and carbon dioxide. Diffusion through intercellular clefts. Gaps between cells in the capillary wall, called intercellular clefts, allow limited passage of fluids and small solutes. Most of our capillaries have intercellular clefts, except for brain capillaries, which are secured together by those tight junctions, forming the blood-brain barrier. Diffusion through pores. So fenestrated capillaries allow free passage of small solutes and fluids. These unique capillaries are found where absorption is a priority, so intestinal capillaries or capillaries serving the endocrine glands, or where filtration occurs, so the kidneys. A fenestra is an oval pore or an opening, it means window, and is usually covered by a delicate membrane. Even so, a fenestra is much more permeable than other regions of the plasma membrane. And four, transport via vesicles. So certain lipid insoluble substances may enter or leave the blood and or pass into the plasma membranes of endothelial cells within vesicles by endocytosis or exocytosis. Fluid movements at capillary beds. So in addition to the exchanges made via passive diffusion through capillary endothelial cell plasma membranes, clefts, fenestrations, and via vesicles. There are active forces operating at capillary beds. Because of their intracellular clefts and fenestrations, some capillaries are leaky, and bulk fluid flow, so a bunch of fluid moving all at once, occurs through the plasma membranes. Hence, blood pressure tends to force fluid and solutes out of the capillaries, and osmotic pressure, or the ability for the solution to pull water towards itself, tends to draw fluid into them because blood has a higher solute concentration as it relates to the interstitial fluid. Whether fluid moves out of the capillary depends on the difference between the two pressures. As a rule, blood pressure is higher than osmotic pressure at the arterial end of a capillary bed and is lower than osmotic pressure at the venous end. Consequently, fluid moves out of the capillaries at the beginning of the bed and is reclaimed at the opposite end, so the venule end, which is what you're seeing here in this image. However, not quite all the fluid forced out of the blood is reclaimed at the venule end. Returning fluid left in tissues to the blood is the chore of the lymphatic system, which we'll talk about in chapter 12. So what you're looking at here is bulk fluid flow across the capillaries. We've established that at the arterial end of capillary bed, blood pressure is more than osmotic pressure and lower at the venule end. And the flow will depend largely on that, again, the difference between the blood pressure and the osmotic pressure. Developmental aspects of the cardiovascular system. So the heart begins as a simple tube in the embryo. It is already beating and busily pumping blood by the 4th week of pregnancy. During the next 3 weeks, the heart continues to change and mature and finally becomes a 4-chambered structure capable of acting as a double pump. Because things like the lungs and digestive system are still immature in the fetus, all nutrient, excretory, and gas exchange occur in the placenta. The umbilical cord contains 3 blood vessels, 1 large umbilical vein, and 2 umbilical arteries. The umbilical vein carries blood rich in nutrients and oxygen to the fetus, and the umbilical arteries carry blood laden with carbon dioxide and metabolic waste products from the fetus to the placenta. As blood flows superiorly towards the heart of the fetus, most of it bypasses the immature liver through the ductus venosus, enters the inferior vena cava, which carries the blood to the right atrium of the heart. Because the non-functional fetal lungs are collapsed, 2 shunts, which we talked about are diverting vessels, make sure that they are almost entirely bypassed. Some of the blood entering the right atrium is shunted directly into the left atrium through the foramen ovale, a flap-like opening in the interarterial septum. Blood that does not manage to enter the right ventricle is pumped out of the pulmonary trunk where it meets a second shunt, the ductus arteriosus, a short vessel that connects the pulmonary trunk and the aorta. Because the collapsed lungs are a high pressure area, the blood tends to enter the systemic circulation through the ductus arteriosus, and the aorta carries blood to the tissues of the fetal body and ultimately back to the placenta through the umbilical arteries. At birth or shortly after, the foramen ovale closes. Its remnants, the fossa ovalis, is visible in the right atrium. The ductus arteriosus collapses, is converted to the fibrous ligamentum arteriosum. As blood stops flowing through the umbilical vessels, they collapse and the circulatory pattern converts to that of an adult. In the absence of congenital heart defects, things like major problems during embryonic formation, when the ductus arteriosus doesn't close, openings in the septum, etc. Generally, the heart will function pretty smoothly for most people throughout the lifetime. Homeostatic mechanisms are so effective that we rarely are aware when the heart is working harder. The heart will hypertrophy and its cardiac output will increase substantially if we exercise regularly and aerobically, and that is vigorously enough to force it to beat at a higher than normal rate for extended periods of time. And the heart becomes not only a more powerful pump, but a more efficient one. So things like your pulse and your blood pressure will decrease. An added benefit of aerobic exercise is that it clears fatty deposits from blood vessel walls, helping to slow the progress of atherosclerosis. However, the once a month or once a year tennis player or snow shoveler that has not built up this type of heart endurance or strength, it does not so much apply to that. When such an individual will push his or her heart too much, it may not be able to cope with the sudden demand, and that's why a lot of weekend athletes end up having heart attacks. As we get older, there are more and more signs of cardiovascular system disturbances. In some people, venous valves weaken and varicose veins appear. Not everyone has varicose veins, but we all have progressive atherosclerosis. There's an old saying, you're only as old as your arteries, referring to this degenerative process. I've never heard that saying. The gradual loss in the elasticity of the blood vessels leads to hypertension, hypertensive heart disease. The insidious filling of the blood vessels with fatty calcified deposits lead most commonly to coronary artery disease. Also, the roughening of the vessel wall encourages thrombus formation. So at least 30% of the population in the United States has hypertension by the age of 50. And cardiovascular disease causes more than 1/2 of the deaths in people over the age of 65. Although the aging process itself contributes to changes in the walls of the blood vessels that can lead to things like stroke and myocardial infarction, most of the medical community, scientists, researchers feel that diet is the single most important contributing factor to cardiovascular disease. There is some agreement that risk is lowered if people eat less animal fat, cholesterol, and salt. And other recommendations include avoiding stress, eliminating things like smoking, and taking part in regular moderate exercise. I want to talk briefly about ECGs, EKGs. So when pulses pass through the heart, electrical currents are generated, which we've established, and they spread throughout the body. These impulses can be detected on the body surface and recorded with an ECG, an electrocardiograph. The recording that is made traces the flow of the current through the heart. So abnormalities in the shape of the waves and the changes in their timing signal that something is wrong with the nodal system. So SA node, AV node. Or that they may indicate a myocardial infarction or heart attack. So there's part of the tissue of the heart that's compromised that can't depolarize. The normal pattern of an ECG is totally lost and the heart ceases to pump during fibrillation. So some essentials to remember. They have 3 normal waves that represent the electrical events that stimulate muscle contractions in the heart. So a P wave, QRS complex, and a T wave. The P wave represents atrial depolarization. The QRS complex represents ventricular depolarization and hides atrial repolarization, and the T wave represents ventricular repolarization. And let's end here by talking a little bit more about atherosclerosis. So again, the disease process in which blood vessels become narrowed by a buildup of fatty and fibrous deposits in the vessel walls. The clogging process begins on the inside. The walls of the vessels, usually the arteries, thicken and then protrude into the lumen, so into the interior of the vessel. Once this happens, a roaming blood clot or arterial spasm can close the vessel completely. So what you're looking at in this image is an atherosclerotic plaque that is nearly like closing up this artery. There is no hole to be seen for fluid. The bracket shows the area for blood flow. So you can see something is completely clogging this up. So what triggers the scourge of blood vessels that indirectly causes half of the deaths in the Western world are the following 4 stages. So the endothelium becomes injured. So the tunica intima, so that interior tunica or layer, can be damaged by bloodborne chemicals, bacteria, viruses, physical factors. Lipids accumulate and become oxidized. So once a break has occurred, blood platelets cling to the injured site, initiate clotting to prevent blood loss. The injured endothelium initiates localized inflammation and summons white blood cells to repair the damage, while allowing things like fats and cholesterol to accumulate just deep to the tunica intima. The inflammatory response in the area causes these lipids to become oxidized and to damage nearby cells, resulting in recruitment of more white blood cells. Some white blood cells, called macrophages rather, take in so much fat that they lose all function and become foam cells. Smooth muscle cells deposit fibers. So smooth muscle cells migrating to the tunica media of the blood vessel wall deposit collagen and elastin fibers to the area and also take in fat, becoming foam cells. Dead or dying foam cells form lesions called atherosclerotic plaques or fibrous plaques that cause thickening of the tunica intima. When these small fatty mounds of muscle begin to protrude into the vessel lumen, the condition is called atherosclerosis. The plaques are often unstable. As cells at the center of the plaque begin to die, the elastic fibers deteriorate and are gradually replaced by non-elastic scar tissue. The addition of calcium salts to the lesion results in complicated plaques. The inflammatory process makes the plaques susceptible to rupture, and exploding off fragments that trigger massive clots can cause lethal heart attacks. Collectively, these events cause the arterial wall to fray and ulcerate, conditions that encourage thrombus formation. The increased rigidity of the vessels leads to hypertension. Together, these events increase the risk for myocardial infarction, strokes, and aneurysms. So treatment and prevention. Lifestyle choices can help improve cardiovascular health in general. So diet low in saturated fat, not smoking, reducing emotional stress. Pharmacological treatments, anti-inflammatory medications, cholesterol-lowering drugs, clot-busting drugs. In balloon angioplasty is a procedure where a balloon is used to compress the plaques against the vessel wall. So they migrate the balloon in, inflate it, and try to push those plaques further closer to the wall. In extreme cases like coronary bypass surgery, a vessel is taken from the patient's leg and grafted onto the affected coronary vessel to reroute blood around the blockage. And the essentials. In atherosclerosis, artery walls thicken and develop scar tissue, resulting in high blood pressure. Atherosclerotic plaques cause thickening of artery walls and can promote thrombus formation. And patients with atherosclerosis are at increased risk for heart attack, stroke, and aneurysms. Any questions, comments, or concerns, please feel free to let me know.